All right, good afternoon, everyone. So my name's Kimon. I'm one of the second-year residents at Temple, and I am both a huge geek about data. That's kind of my happy place, and I'm also a former high school math teacher, so I'm going to hope to bring those skill sets together and make the sort of slightly wonky topic of machine learning relevant and accessible for you guys as an EM audience. So our agenda today is pretty much going to follow the title, but we're going to sort of switch the order up and start by defining machine learning. It's a form of artificial intelligence that basically takes a huge amount of data and throws it into an algorithm. So for example, you can have a whole bunch of pictures of cats and a whole bunch of pictures of dogs and put them into a machine which sorts through them and on its own, learning autonomously without the direct assistance of a human, comes up with an algorithm to predict whether or not when you put another photo back in, whether it's a cat or a dog, in essence. And the algorithm inside looks like a very complicated decision tree with maybe thousands of different steps and transformations. And this ends up being useful not just for, figuring out what's a cat or a dog. We can do that already. But for example, Facebook uses this technology now. Whenever you upload a picture, it sorts through your friends and tries to figure out which one of them is in it and suggests that you might want to tag them in it. But the same technology can be applied to a piece of clinical data, like, for example, a chest x-ray. This is already being done. And we could see this in clinical practice, maybe suggesting, like, hey, do you want me to go ahead and call this a pneumonia and put it in the chart for you? You could even look at pulmonary nodules. The same sort of machine learning technology Dragon already uses to improve the transcription technology that they have. But Siri already in our iPhones goes even further and understands the meaning of what we're saying and can help us take action. To go even further in the clinical context, Amazon and Netflix are very, very good at looking at what we've done in the past and making predictions as to what we might do in the future. And you could similarly look at a patient's chart and see what's happened to them in the past and what they might be at risk for in the future and make some suggestions as to how to take action on that. This slide's a little messed up, but the good news, I think, for us is that our jobs are not in question with a lot of this technology. Ultimately, these give us tools to take over some accessory functions of our jobs, but we're generalists, and we have an integrative function, and it's really going to help us out in the long run. The bad news here is that a lot of these tools don't give us clear yes-no answers. They give us probabilities and percentages, and I think that makes a lot of people maybe appropriately anxious and skeptical. The reality is we have a zero-miss culture in emergency medicine, and we're uncomfortable with the notion that we might be wrong or that computers that we use might be wrong. But I think what we're going to have to do is really rigorously compare the algorithms and the humans and figure out what is the miss rate for the humans. There is a miss rate. What is the miss rate for the algorithms? And figure out in what situations the computers are better and what situations the people are better. And this is going to be a tricky debate. But I think we've actually already been through a lot of these issues in emergency medicine as clinical decision rules, like for example the Wells score, have become really entrenched in our practice. And I'm going to go over three main issues that really decision rules and machine learning have in practice. So number one is this idea of overspecification or overfitting. Basically, this means that when you develop a model, it starts to fit sort of idiosyncrasies of the data as opposed to the actual overlying pattern. And this is even more of an issue with machine learning because the models are so much more powerful. Number two is external validity. If the populations we develop these tools on are not the same as the populations we're applying them to, they're going to be totally invalid. And number three, all these tools are predicated on the notion that there's some sort of gold standard diagnosis that humans come up with. But if those human decisions are somehow biased or discriminatory, we run the risk of actually perpetuating some of those biases in the machine tools that we start to use. The way to avoid a lot of these issues is going to be to rigorously test and validate any tool that's coming into our emergency departments with our patients, maybe in our very own emergency rooms. This is something that we've sort of started to do in our emergency department as we've thought about using these normal EKG machine reads to maybe change our triage process. And we've had to carefully look at our own data with our patients, figure out what is the chance that we might have a miss versus what is the potential safety benefit of reducing interruptions for a lot of our docs. So bringing all these things together, I don't think machine learning is going to take our jobs. If anything, it's going to make our roles even more valuable in the healthcare system. We just have to be really mindful of a lot of the same issues that have come up with clinical decision rules and make sure that we really rigorously test and validate any tool before we subject our patients to it. Thank you so much.
Kevon? All right. Judges?
Thank you. That was a great presentation. You mentioned the comparison, obviously, which is quite clear, the comparison to the previous or the current generation of decision rules. And my sense is that we've not done a great job. We have sort of removed, we've taken decision rules that we have, in most cases, we've not proven that they're better than our unstructured gestalt. And they've often come to take over clinical practice. We often talk to residents. It's like, what do you think the diagnosis is? Don't like throw like acronyms at me. What do you think is going on? What steps would you recommend in the 1 minute you have, or a step, to make sure that this time we do a better job?